I have the privilege to talk about MRI-guided radiotherapy, and I think the field has come a long way. Remember when I came to Taiwan, I spoke about it at smaller hospitals, but I think now we have more data on this topic I'm happy to share with you all. These are my disclosures. So kind of brief outline I'm going to talk about today is the history of MRI guidance, some of the intrinsic advantages of using MR during radiotherapy for imaging, tracking of the tumor, and near real-time online adaptive therapy. Some of the emerging clinical evidence, either retrospective or some early prospective phase 2 trials showing feasibility but also potential for better outcome using this technology, and where we're going with, in general, MR-guided functional imaging approaches. Currently, there are two commercial systems for MR-guided radiotherapy. There's the Elekta Unity system and then the ViewRay Meridian system. The difference between them mainly relies in the imaging and the strength of the magnet, with the Unity having 1.5 Tesla magnet and the ViewRay Meridian using a low field 0.35 Tesla magnet for a number of reasons to do that. And as I mentioned before, the benefit of MR guidance is summarized by its ability to be able to visualize anatomical motion in real time, be able to have a superior soft tissue imaging, enabling planning and also adaptive planning, and then finally using it for an online adaptive therapy to change the radiation plan while the patient's on the treatment table, followed by eventually the potential for functional image-guided radiotherapy. So I'm going to mainly focus on the Meridian system because that's the one I have the most experience with. And initial prototype used MRI-guided cobalt therapy in order to be able to deliver the radiation with the magnet on. The second generation technology has unique capability for shielding, preventing the magnet to interfere with the trajectory of the electrons, conversely also shielding the electronic component of the LINAC from the MR imaging so that it preserves the fidelity of the image quality with minimal imaging artifacts. And some of the other features of the MR LINAC here is that it uses 6 MV filter-free mode, no bending magnet, relatively high delivery rates, double-stack MLC that allows for less leakage and sharper beam, and then as I mentioned before, 6 magnetically shielded compartments to be able to have the LINAC deliver treatment while the magnet is on. There are other systems that are either in prototype mode or just recently FDA approved. I'd like to highlight the third system, which is a Canadian system called Magnetic TX. With the difference between these systems include that this one is the magnetic field is the only one that's in parallel with the LINAC, and this also with the open bore allows for a larger field size, and the open bore also leads to less or no electron return effects, therefore lower dose in the air to tissue interface and no electronic streaming effects, which can produce unwanted skin doses and causes toxicity. Some of the history of the MR LINAC is displayed here. So this technology was first implemented to treat patients in January 2014 at WashU. I had the privilege of starting the program at the UCLA with our MR LINAC in October 2014. And subsequently, there's over 50 units in the country. The first MR LINAC with the Meridian was in Henry Ford. That was in July of 2017. So we started with the first patient in October 2014. And this patient was treated with sort of feasibility, non-gated treatments, followed by the first gated treatment was in 2015. After our team were able to quickly credential the gating capabilities and verify that its accuracy. And then we treated our first adaptive on-table treatment a few months after that in August of 2015. As you can see, the table or the summary here was all the patients that were treated with the MR Cobalt system, about 379 patients in totality, where more than 2/3 were treated with SBRT, and that trend is furthered by current technology, where I would say 95% of the patients treated with MR-Linac are SBRT patients. This is from the company, and this is still already out of date, but there's probably nearly 20,000 patients treated with this system as the leader of the MR-guided technology. There were 4 centers that have treated, over 1,000 patients, and that's WashU, Seoul, Korea, Amsterdam, and UCLA most recently. There's been 2,200 plus SBRT pancreas patients treated with the MR-Linac in the world. And across the world, you can see here geographically, most of the centers are in the US, Europe, and actually a number of centers in Asia have MR-Linac, most notably here, I think, in Kaohsiung, and I was told that there was a unit in Taipei that will be starting treatment later this year. So as mentioned here, one of the benefits is MR guidance is motion management. And as radiation oncologists, we've been chasing the ability to manage motion since the early 1990s, up until with technology such as fiducial markers, Calypso, using Accuray synchrony to be able to track tumors with a CyberKnife, and then followed by use of things like ExactTrack for a non-coplanar X-ray imaging. However, the only system that could track tumors in real time continuously without added dose, really right now is the use of MR imaging. And this sort of has been taken also to improve with the initial version displaying images at 4 frames per second, and now the most latest version upgrade is 8 frames per second in real time. And intuitively, we know that if we can't see something, we can't really treat it accurately. I like to highlight an example. I think the world record for number of free throws blindfolded is like 12 consecutive free throws, whereas open, it's like 260 free throws consecutively. And so when you can't see something while you treat, you know, what you typically have done is use larger margins because we don't want to miss. However, using larger margins becomes not practical when there's neighboring critical tissues where we're trying to spare with ablative doses. Otherwise, we then limit the prescription dose and then lower our doses such that we're below the tolerance of the organs at risk. And that's also suboptimal when we're trying to ablate tumors with relatively radio resistance. This slide shows some of the simple examples of the benefit of superior soft tissue imaging using the MRI-guided system. So on the left panel is a tumor in the liver, not visible on a contrast CT, but highly visible on a MR, view-rate MRI image. The middle panel shows a patient who had surgery, a lumpectomy for a right-sided breast cancer, where larger margins are used for partial breast irradiation because you can't really see it on the daily cone beam CT versus the MR-Linac. And on the right is a tumor also in the liver. On this one, the top panel is a non-contrast, low-field MRI image on the system, highlighting that not all tumors are visible. However, many centers, including ours, had used contrast agent doing the planning and also doing each fractions of the SBRT, namely EOVIS, to be able to visualize the tumor during treatment, which has been an effective way to manage tumors that are not highly visible on a low-field MRI. This work is done by some of the physicists at UCLA who were involved in developing the 4D MRI imaging at our institution. As you can see here, this is a patient who's had multiple treatments, including SBRT and Y90, and with the residual liver tumors, compared to, on the bottom, a 4D CT that shows some of the inadequacies of visualizing the target, but also motion artifacts during the 4D CT displayed below the actual target. We wanted to quantify the difference between use of 4D CT for managing motion for lung tumors versus MRI. So our early experience, our patients were treated with a non-gated approach using ITVs, and we were able to obtain sitting MRI images over 20 minutes versus a standard 4D CT or MRI over 10 seconds to compare the degree and variability of motion on an individual patient and fractional basis. So essentially, this shows 5 patients with lung tumors, and each of the patients had either a 4D CT or MRI over 20 minutes. Each of the patients, some of these patients show the degree of differences in ITV size between the two imaging approaches, but also on a daily basis, the degree of motion varies within the patients based on that day, the patient's ability to be able to breathe in the normal fashions. So this slide, I don't know if the audio will work, maybe not, but this slide, if you could just look at the movie, this is a display of how in real time a liver tumor can be visualized relative to the target, which is smaller with a smaller margin. And the patient is able to be coached in such a way that you can tell the patient to let out more air or have them visualize a feedback loop such that you can train the patients to locate the patient's tumor within the target volume and minimize toxicity and missing the tumor by treating the entire ITV, for example, in this relatively mobile liver tumor. But besides kind of intrafraction, besides sort of treatment-related motion during that fraction, there's other changes that are difficult to account for. For example, tumor anatomical changes from regression or progression of disease, weight loss, or tumor and OAR biological changes. These are more systematic and potentially predictable. However, positioning of the patient, morphological volume changes during the treatment, or positional change relative to the target, these are relatively stochastic incidents and difficult to predict and difficult to manage without the ability to on-tably adapt the treatment on a daily basis. And the question is, can these changes lead to clinically unacceptable deviations? And if so, how do we account for it? Here's the picture shows a patient with just between the CT simulation and the MR simulation, or sorry, the initial simulation and the fraction 9, the stomach is displayed by more than 5 centimeters in a craniocaudal dimension. Here's another example of a CT simulation for tumors in the abdomen, adrenal tumor. 45 minutes later, the MR simulation is done, and there's significant change in the location of the small and large bowel just between 45 minutes. So imagine you do a plan, and shortly after that, it becomes irrelevant. So this could be adapted in such that we can still spare the normal tissue on the day of treatment. So essentially, the online adaptive process is to account for stochastic changes of the critical organs. It allows for potential to dose escalate and improve treatment tolerance with the reduction of side effects with the very sensitive radiosensitive tissues around the target. It mandates really high-quality onboard imaging to be able to do this. Our current cone beam CT is unable to do that. And highly efficient planning tools are necessary to expedite the process so that it's not as time-consuming, labor-intensive as the first generation of treatments. And I think we also have to rethink the concept of PTVs, for example. So in some cases, when surgeons operate, they don't have a defined amount of margin. The margin is defined by how much they can resect based on what normal tissue is surrounding that and how close it is. So for example, for radiation, in the plan, maybe a 5 millimeter margin is fine because the organs at risk are relatively farther away. On the day of treatment, though, potentially you have to shrink our margins to 3 millimeter because the duodenum in the stomach, in this case, is closer to the target in charge. But does that matter if you're able to deliver ablative doses to the tumor in a high-fidelity manner? Our initial process, when we first started UCLA, required multiple stakeholders in this process, including radiation therapists, physicists, dosimetrists, physicians, and we defined the role and sort of secondary role in this process because our planning is being condensed from a week down to potentially 45 to 50 minutes. And these steps are similar at other institutions, but the people that are doing these steps may be different. And the initial process, as you could see, the timing from rooming the patient all the way to treatment and adaptation is 54 minutes, which is quite a long time. So we started to develop the process of care for this. And in some ways, we learned from our surgical colleagues that we kind of are focused on the treatment itself rather than the pre-planning process. And we developed these tools, forms that inform the covering physicians what our intent is, because it's impossible for the treating physicians to be available to do the adaptive therapy on each fraction. So we define what kind of metrics we would use to trigger adaptive replanning based on the OIR violations or on PTV coverage. We define sort of the process where the physicist will generate the readaptive plan based on what was done initially with ring structures and optimization. And this process kind of led to us to be able to make the process more uniform and less time consuming. And this has been iterated again. This was actually a recent paper that a number of MRI centers participated in, again, to define what is the optimal sign out in this process when a physician signs out to their colleague, to be able to express the intent of the treatment plan that the treating physician would like. For example, again, what do you contour and how much of the ring structure do you contour? So because it's very labor intensive, we all figured out that doses with farther than 3 centimeters from the target probably is irrelevant. So then we defined a volume where we would adjust the contour doing the adaptive process. So in this process, we learned that we're trying to compress many, many days of work into a 25 to 45-minute period. It allows for potential mistakes because of the time pressure. And so multiple checks and balances needed to be in place so that, for example, if physicians might check, or physicists might check the physician's work while they are doing the recontouring, making sure that's adequate. And this has certainly been aided by a software tool and upgrades from the company that has allowed us to truncate that time down from 45 minutes to probably 20 to 25 minutes on an individual basis. Their latest software allows for better soft tissue imaging and also parallel workflow such that the physicians, the RTT, and the dosimetrists can simultaneously work on this treatment adaptive plan process in parallel, so that will take less time. Oops. And it also has faster tracking and automation of the beam gating in this latest software. So, but some of the earlier lessons we learned here was that, again, when we try to treat tumors of a certain location, we don't expect perfection of the contouring because if something that's sort of 5 centimeters, for example, this outer edge of the bladder wall is not contoured appropriately, it doesn't affect the dose because beyond 3 centimeters, the dose falls relatively quickly. On the right was an early example of a patient with pancreas tumor where we were doing adaptive replanning on the treatment table and realized that the replan actually made the kidney dose worse because even though it was an organ that was contoured, it was not used in the optimization because it was farther away, but on the day of treatment, because of other anatomical variations, optimization was needed to be able to spare this right kidney, and so that was replanned again to be able to do that. And so human intervention is still needed, even if this process is automated, to be able to optimize this treatment process. But when it's possible, you could see the benefit, at least dosimetrically, for being able to do on-table adaptive treatment. This is a tumor in the peritoneum, highly mobile, adjacent to bowel structures. And on the day of treatment, you could see that the 35 gray isodose line crosses some of the soft tissue structure of the bowel. And by readapting, we were able to reduce the V35 gray to 0.05 cc in this plan. This was a patient, one of our first adaptive patients at UCLA. She is a breast cancer survivor with oligometastatic tumor in the abdomen, near the stomach, pancreas, liver, and duodenum. Highly mobile in a way that the radiologist, interventional radiologists, felt it was unsafe to ablate because of proximity to bowel and also the bile duct and the pancreatic duct. So we treated her with SBRT, 40 gray and 5 fractions, on a daily adaptive basis. Here's the pre-treatment PET scan, and these are the post-treatment PET scans after more than 2 years. And from each of the fractions, the variation in stomach filling was seen here in such a way that the stomach was actually closer to the tumor on one of the fractions, and would have, if we treated with the original plan, would lead to a significant overdose of the stomach wall, potentially causing a complication. So we did the on-table adaptive replanning, and so the solid line was the original plan, showing excellent sparing in the stomach because if it's farther away. The more thicker dashed line here was the original predicted plan. If we were to deliver that same plan that we had, would have led to this sort of dose volume histogram for the stomach. Particularly, we care about the high dose to a small volume, for example, anything greater than 33 gray. And so we, by adapting this treatment, we were able to lower the V33 gray from 8.9 cc to down to 0.5 cc. And we were able to do that iteratively on each of the fractions. She did well, and she actually was on TV highlighting this technology, and she was quoted as saying that it's intuitive that she would want the physicians to be able to change the plan on a daily basis if her anatomy is in such a way that we should be harmed with the same treatment plan. So after we treated about, I'd say, 30 to 40 adaptive cases, we wanted to go back and kind of look at our process of care and see if the correct decisions to adapt were made. So working with a visiting fellow at that time from France, we went back and looked at our pancreas cases. And our original process was when the patients came to the treatment table, we lined them up, we set up her imaging, and then the physician would eyeball and say, does it look like the anatomy has changed or not? If the physician felt that the anatomy is very similar, we didn't go through the process of recontouring and online adaptive therapy because it was taking too long, and they just treated with the original plan. If the physician felt that the online adaptive therapy was needed, then they would go through the process of predicting what the dose would be on today's plan, and then re-optimization. So we went through the process when we retrospectively went back and re-optimized and recontoured each of the fractions, and we saw whether the right decision was made or not. So of the 5, we picked 7 pancreas cases, and on the right it shows what actually happened on each of the fractions, A being adapted, P means we predicted, but we felt that the original plan was adequate, and the rest were just treated with eyeball check and says, okay, everything looks good. Of course, we use the same constraints for target volume coverage, and also the decision to adapt was the same, whether based on normal tissue dose constraints, whether we would do adaptive replanning or not. And it turns out, for example, in this example where a patient was not adapted, if you were to go back and recontour the duodenum, you would see that the blue line, which is the recontour of that day's anatomy, showed that the green 35 gray volume would overlap with that part of the proximal duodenum closest to the tumor, and it could potentially cause harm. So with the 35 fractions, 14 were actually adapted. Of the ones that were not adapted, 25 of the 35 fractions, if we contoured everything, would have met the criterion for adaptation, which meant that of the 21 fractions not adapted, more than half should have been adapted based on the criteria if we had just contoured each fraction. So from that study, we changed our process such that the physician on call would recontour every case, whether or not they felt that the anatomy has shifted or not. So the question of recontour or not was answered, and the ideal situation is that recontour should be done because we're talking about very small changes to the volume at risk, and that's impossible to perceive with just a simple eye check. So the current process would be a patient is imaged, a rigid couch correction is done for rigid mobilization, the contours review, contours are readjusted based on that day's anatomy, the dose is predicted if we were to treat that patient based on the original plan. If the answer is yes, because the doses to ORARs have changed or coverage is reduced, re-optimization is done, and then it's QA'd in a separate process with the planning, and then imaged and then treated with a new plan. All this is now down to about 25 to 30 minutes on each case basis. So we've highlighted some of the advantages of MRI-guided radiation. So here are some of them again. So soft tissue, superior soft tissue contrast allows for better contouring of the target OARs, allows for setup during the daily treatments, allowing potentially eventually to monitor variation in response. Eventually, functional physiological imaging can allow us to, again, adapt the therapy based on biological change. And real-time imaging allows for motion management based on the target itself, not on a surrogate or on some some sort of larger ITV volume that might treat more normal tissue. So I'm going to go through some of the clinical evidence across a number of cancers. Overall, MRI-guided RT has been treated essentially for all tumor types, as listed here. Here's a breakdown of the types of treatment by sites. Most of them, oligometastases, prostate, pancreas, liver, and some lung tumors. Now, over 86% of the treatments are SBRT. Across globally in the US, you can see as far as the tumor types and the percentage of SBRT, where pancreas leads the way as far as percent SBRT patients and percent adapted. Almost all patients that have pancreatic tumor need daily adaptive replanning, as opposed to, say, lung and liver, where less than 50% are adapted on a daily basis. This was one of the first study prospectively that looked at outcome with MRI-guided RT for prostate cancer. This was then at the Amsterdam AUMC of over 101 patients with intermediate high-risk prostate cancer treated with SBRT, 7.25 gray per fractions, no fiducial markers, no space OAR, and they showed that they have very low early and acute GU and GI toxicity at 3 months. They powered the study to the Dutch HyPro study, and basically they were showing that the maximum grade 2 and above early GI toxicity was 5% versus 15% on the other trial. The rates of incontinence was uncommon, and also the rate of GU toxicity was very low. Building on this experience, Amar Kishan and colleagues performed a phase 3 randomized trial of MRI-guided SBRT for prostate versus CT-guided approach. The hypothesis is that using MR and better imaging, you could reduce the margins from 4 millimeter to 2 millimeter and reduce the QGU toxicity of grade 2 and above from 29% to 14%. Original sample size based on a power calculation was 300 patients. After 100 patients, interim analysis was done to determine whether there is a benefit or a futile in this study. So overall, they treated 178 patients, and at the interim analysis, they actually were able to show a benefit such that the DSMC stopped the trial early. Approximately 88 to 90 patients were randomized to each of the arms, and evaluable patients include 76 and 78 in each of the arms. This was the outcome of the study, showing that patients that were treated with CT versus MR guidance, the MR-guided patients with smaller margin has less urinary incontinence score, reduced bowel toxicity, and also overall MR guidance was associated with a smaller decrement in a smaller percentage of patients with greater than or equal to 15-point decrement in IPSS score, and also reduction in percentage of patients with clinically significant decrease in EPIC-26 score, basically showing that in all domains, patient-reported or physician-reported outcomes, that the MR-guided SBRT cohort has less GI and GU toxicity. And this was not without adaptive treatment. It was simply reduction of margin with better confidence to do SBRT with 2 millimeter margins. So they concluded that aggressive margin reduction was able to reduce GU toxicity. It was a primary endpoint. There was also reduction in acute GI toxicity. The strength are that it's a randomized studies, but however, the limitations are that there's uncertainty whether this translates to a long-term benefit for these patients. Similarly, in locally advanced cervix cancer, there's data to suggest that using MRI, patients are able to have reduction in GI toxicity and GU toxicity. In this smaller sort of retrospective comparison study of cervix cancer. And it's an ideal situation because these tumors, as you know, will require a higher dose, but also will shrink significantly during the treatment, optimally for adaptive replanning during this process. For breast cancer, this study from WashU of 50 patients showed that patients can be treated with single fraction partial breast irradiation, delivering 20 gray to a surgical bed, and with a 5 gray boost to the PTV. 5 gray boost to the PTV and 20 gray to the surgical bed. The median follow-up was 25 months, and they showed that there was no grade 3 to 5 toxicity, but also that the cosmesis pre-treatment at 8 weeks and 6 months, both by patient and doctor reported outcomes were excellent. Moving on to oligometastatic disease, early on today we think I'm sure Dr. Tsai presented on the SABR-COMET trial showing a benefit in overall survival for patients with oligometastatic cancers of various histologies. There's ongoing trials at Anderson and other places looking at oligometastatic lung cancer using either with immune checkpoint inhibition or EGFR target therapy or other targeted therapies. We looked, as a consortium, we looked at the patients treated with liver oligometastases across 3 institutions using SBRT with a median dose of 50 gray in 5 fractions. 1-year survival was 69%, 2-year survival was 60%. There were no grade 4 plus toxicity and low grade 3 toxicity overall. At UCLA, we had a prospective trial using ablative radiation as a phase 1 dose escalation trial. And basically, we really showed that SABR for liver mets is feasible with the MRI original Cobalt system with a 2-year local control rate of 95%. When we stratify by biological effective dose, similar to other studies, BED greater than 100 was able to show a difference in local control. In this study, there was no acute grade 3 toxicity. There's 1 late grade 3 toxicity from a single patient where in retrospect, the V35 grade of small bowel was violated. We didn't have that as a constraint in the early experience because we didn't realize that we needed to counter individual loops of bowel, and subsequently that we changed our protocol and we didn't experience another toxicity of that nature. Moving on to pancreatic cancer, again, similarly, some of our early institutions met to pull our data from 5 institutions looking at outcomes for using MR-Linac. This was a retrospective study of 44 patients out of these institutions where we looked at the biological effective dose and how that translates to outcomes in survival, local control, and toxicity. Because of the various ways pancreatic cancer is treated with fractionation, hypofractionation, or SBRT, we were able to stratify by different doses and basically show that higher doses led to better survival and potentially better local regional control. But surprisingly, even though we gave some of the patients higher than 90 gray BED, most of these patients were adapted when we went that high. There was actually less toxicity when we gave escalated dose, again, suggesting that maybe the adaptation kind of led to this benefit in reduction in toxicity. This led to a hypothesis that smart MR-guided adaptive RT could potentially be done on a prospective manner. And this study was just presented at the last ASTRO meeting as a late-breaking abstract and is currently being reviewed at a journal. This was a prospective trial of 136 patients delivering 50 gray in 5 fractions of pancreas SBRT using daily on-table adaptation with the primary endpoint of GI toxicity greater than grade 3 at 90 days, secondary endpoints of survival, quality of life, distant metastases. Patients needed to be given at least 8 to 12 weeks of systemic chemotherapy, followed by not randomizing, but enrollment to this cohort giving 50 gray in 5 fractions, but limiting to OARs to the doses that are known to be safe. Overall, these are the patient demographics showing that most of these patients had tumors of the pancreatic head. All the patients had essentially dual systemic therapy, and that about 43% of the patients had borderline resectable pancreatic cancer. These were all the institutions that enrolled on the trial. Patients mostly have FOLFIRINOX and gemcitabine Abraxane, and the radiation was done in this manner where the dose covering the GTV was approximately 42 gray, because again, this is not 50 gray was a nominal dose, but it was limited by how much the OAR received. And these are the treatments post-SMART after in the trial. So here's an example of a large pancreatic head tumors where you could see that the 33 grade is not hitting the small bowel and large bowel or duodenum. The results, the primary endpoint was grade 3 or higher toxicity related to SMART, and that was 0%. But when we looked at all grade 3 toxicity that were definitely, possibly, or probably related, it was approximately 8%, which was still less than the pre-trial hypothesis of being less than 15%, which was based on the previous studies. These were some of the toxicity, again, related, whether it's definitely, probably, possibly. Some patients had some of these toxicity that were possibly attributable to radiation. The outcome as far as tumor-related outcomes were still early because of the early follow-up, but the 1-year survival was 94%. Median survival at 18 months was 75%. And on the right, it was a breakdown of patients either with borderline resectable or locally advanced pancreatic cancer, showing that obviously patient with borderline resectable cancer did better. So the conclusion for this study was that it's feasible to deliver SMART across a variety of practice settings. Survival data was promising but need longer follow-up, and as far as toxicity and also 2-year survival will be tracked. The next study using this approach would be, this study it's going to be led by Michael Chung at the MCI in Florida, looking at, it's called LAP-ABLATE, randomizing patients after 12 cycles of FOLFIRINOX or Gem/Abraxane in a 1-to-2 manner to standard of care chemotherapy versus ablative radiation with MRI guidance. And the endpoint is 2-year overall survival with chemo plus SBRT with MR-Linac. So from our original SMART study, we were able to go back and look at some of the plans of the adaptive treatments. And we met as a group of the PIs to look at the adaptive fractions and score them whether they met criterion or they had major violations. In this example, I want to demonstrate that when we looked at each of the fractions, some of them wasn't like just like the original study I showed with our UCLA data, that some of the normal tissue wasn't contoured appropriately. For example, here's missing some pieces of the bowel tissue adjacent to the tumor, where that the 33 gray would have overlapped with that. So of course, it's important to characterize the toxicity relative to the quality of the adaptive contour, and that will be the next paper that we'll be publishing. Here's another example of another patient, again, where the treated adaptive plan under-contoured the part of the duodenum that's closest to the target. And we look at the dose, that piece of bowel could have gotten at least 33 gray and likely would have led to some clinically relevant outcomes. So here are the study for various studies at the phase 1, phase 2, and phase 3 level. We talked about the MIRAGE prostate trial, the future LAP-ABLATE trial, and some of the other trials that are ongoing at either single institution, multi-institution, looking at the potential benefit of SMART in the various contexts. Here's, again, some pancreas trials that I mentioned before. Prostate, there are trials to look at shortening the treatment for intact prostate, but also possibly using prostate SBRT for salvage radiotherapy rather than 20 or 35 fractions. There's a trial for using 2 versus 5 fractions for prostate SBRT that's ongoing. There's a study in lung called LungStar looking at the safety of using SMART for centrally located lung tumors. We know that potentially with Linac-based large volume, the HILAS trial had a significant grade 3 and grade 5 toxicity, whereas a recent study from the Netherlands, again showing using retrospective showing SMART for central tumor had 8% grade 3 and no grade 5 toxicity. So this LungStar is to validate those data prospectively. Finally, in the last few minutes, I'd like to talk about functional imaging. So one of the benefits of MRI is to be able to track functional changes, like, for example, diffusion during treatment. We know that tumors with high densities led to lower apparent diffusion coefficient, but with treatment, if response, the ADC values could potentially lower and be a biomarker for treatment response. So early on, we had a protocol at UCLA where we track the functional image capabilities of this low-field MRI across various tumor types. We're able to score things like sarcoma and their ADC values on each of the fractional bases. Here's a head and neck cancer showing that the spinal cord as a control has no change, but this head and neck cancer has decreased in ADC, potentially suggesting treatment resistance, versus this other patient where the ADC value increased and potentially showing a response. Very early data showing that potentially this could correlate to biopsy-proven recurrences. And in the other study here in rectal cancer, we also did the same because all these patients went on to surgery, and we were able to track areas of low diffusion changes such that we correlated the amount of ADC change to their pathological response, with those patients that had increase in ADC value have a more likelihood of responding to the therapy. Again, this is very early, very few patients and more of a feasibility study. This is the ICU report that's actually available. That's been worked on for the last 2 years, looking at developing a standardization of the current state-of-the-art for MRI guidance and also the future MRI guidance. It's quite long, but it has all information up to date as far as 3 months ago, as far as the clinical trials that have shown benefit and ongoing trials. That's my last slide. Oh, actually, that's not my last. I have a few more slides. So, you know, like everything else, I think AI is going to change how we do things. And what is the role of radiation oncologists when AI is going to do everything for us? I would argue that, you know, we are still very early on in this process of MRI guidance, almost like, you know, the first time we flew an airplane. But nowadays, it's so sophisticated that we still need the pilot, but their job isn't to fly the plane. It's more to do the other things to make sure that there's a safe journey. So in my view, I mean, many of us who have used this technology feel like AI will allow us to simplify the decision-making such that we're not doing the recontour per se, but it's allowing us to make decisions about potentially functionally adapt and increase doses to a subpopulation of the tumor, maybe enhancing the outcome for these patients. So this is close to my final slide, but I would say that this is a slide for technology adoption. And there's always often a technology die early on when there's lack of adoption because how much work it takes to make something standard of care. We're probably past this chasm, but we're still in the early adopter phase where we're trying to show evidence that this technology has a place in radiation oncology and beyond. So summary, MRI guidance is, in my opinion, a fundamental change, much like IMRT, IGRT, or SABR in the last 50 years. It combines a unique set of benefits with quality of imaging, motion management, and ability to replan that allows us to personalize the treatment. The versatility allows us to treat simple to very complex cases. In the US, at least, with the pressure to reduce the number of treatments, this actually aligns it very well so that we can deliver high-quality hypofractionation. And, you know, I'm at a new center at Orange County, and we're excited that we will be bringing on this technology in the fall of this year. Thank you very much. So we have time for questions. Yeah. That's a good question. Yeah. Yeah, I always think it's really a good opportunity to look at brachytherapy. I don't think we're quite there yet, but I think it has some potential to be able to do that because, you know, you can track it in real time, you could dose escalate, you could paint specific part of the tumor. But I'm sure if you speak to the pure brachytherapists, they would say no, nothing's going to be able to replace sort of the dose distribution of brachytherapy. Yeah, 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 yeah. I think it has potential for sure. Okay. No further questions? We take a 5-minute break?